Welcome to the Modrn Wellness Podcast. I'm your host, Dr. Mary Pardee. This podcast, along with my private practice in LA and my newsletter, all are aimed to providing you evidence-based information around preventative medicine, longevity, and health in general. Join me in dispelling health myths as well as cutting through the noise that is social media. I hope that whether you want to optimize your performance or just in general get healthier, the Modrn Wellness Podcast will help you do that. I'm here today with Dr. Matt Kaeberlein, who's the CEO of OptiSpan and the host of the OptiSpan podcast, which I am a huge fan of. He's also an affiliate professor of oral health sciences at the University of Washington and a co-founder of the Dog Aging Project. Dr. Kaeberlein is deeply committed to advancing human and animal health by developing new technologies for health optimization and targeting the biological processes underlying aging and age-related disease. He has won so many awards that I cannot list them today, but I will put in the show notes. And he's published over 250 scientific papers on longevity. So welcome, and thank you for coming down. I really appreciate it.
Yeah, it's a pleasure to be here. And I'm loving the sun here in LA, getting out of Seattle.
Yes, you missed the fires.
Thankfully.
Yes. But we were left with the sun, which is nice. And I'm really excited for today. I've been looking forward to this podcast. We've had the craziness in LA, and me and Nick have been emailing, and I'm like, no, we're going to do it. I'm going to figure it out. It might not be at the same place, but here we are.
Yeah, I'm glad we were able to pull it together. So this will be fun.
Me too. So today I really want to focus on, you have so much knowledge, and we could go so many directions with this. We'll probably want to do a repeat if you allow me to, but today I really want to focus on rapamycin.
Okay.
This is something that comes up all the time in the longevity space, is something that I personally am still combing through the research and considering for my patients, myself, all of the things. I had Dr. Daniel Promislow on the podcast. If you haven't listened to that one, we talk all about the Dog Aging Project, which you're involved in and involves rapamycin as well. So my listeners know a little bit, and now we're going to do the deep dive.
Great.
Cool.
I love talking about rapamycin.
Yay. Yeah. Okay, so first, kind of backing it up, what causes humans to age? Just a simple question.
Yeah, I think, it's not a simple question. It's actually really complicated. But maybe one way to think about it is I've studied aging really at the genetic and molecular level. And we've learned a lot in the last 20 years about what the cellular processes are that drive aging. So that's where my mind immediately goes. And I think the easiest way to frame this is through the lens of what we call the hallmarks of aging. So there are now these 12 hallmarks that seem to be shared about the aging process across the entire animal kingdom. So all animals seem to have these processes that drive aging. And we know from studies in laboratory animals that if we target individual hallmarks of aging, we can have a positive impact on either lifespan or certain metrics of health span, the period of life spent in good health. So we don't need to necessarily go through all 12, but they include things like telomere shortening and DNA damage and mitochondrial dysfunction. I think in people and mammals, so companion animals like dogs and cats, even mice, inflammation is one of the 12 hallmarks that is really seems to be important, and most age-related diseases involve some aspect of chronic inflammation. So anyways, there are 12 of these things, and that's not all of aging, but it's a part of the picture. And I think, again, the important message for people to understand who maybe don't think a lot about the biology of aging is that we know enough now that we can start to target that biology to have an impact on health and potentially on lifespan in humans. And so you mentioned the Dog Aging Project. Really, the Dog Aging Project is in some ways a bridge between studies in laboratory animals and bringing this to application in people by studying the aging process in companion dogs. So these are dogs living with their owners. We don't do anything with dogs in a laboratory or captive animals, because companion dogs share the human environment, which is something we don't study in the lab. And they age biologically about 7 to 10 times faster than people do. So we have an opportunity to really study what are the genetics, what are the environmental factors that are most important for the biological aging process, the hallmarks of aging in companion dogs.
Yeah, and I think that brings up a really good point, especially for those who aren't in the research field, where one of the reasons, tell me if I'm wrong, but that we don't know as much as we potentially could know about aging and longevity is humans live a long time.
Yeah, well, especially aging in humans, right? And that's part of the reason why historically most of the studies on the biological mechanisms of aging have been done in laboratory animals that are short-lived, because we can do those experiments in a time frame that allows us to, tweak a gene or use a small molecule and see what the effect is on lifespan and the rate of aging. So the common model organisms that I've studied throughout my career include single-celled yeast, which take a few weeks to measure their lifespan, nematode worms called C. elegans, which also take a few weeks. Done a little bit with fruit flies, not a lot. Those take about 3 months. They go through this aging process. And then mice in the laboratory will live about 3 years. So you can see there's a pretty big range, but all of those animals age much more rapidly than people do. And that allows us to start to tease out mechanisms of aging. In humans, at least so far, we've been sort of constrained to large-scale population correlative studies. We can say certain people tend to live longer. Certain people tend to get diseases of aging earlier. We can identify some genes that are associated with that, but we really don't know that that's what's causing the differences in lifespan in people.
Yeah. And you were recently on Dr. Atia's podcast. And I remember one of the topics that you covered there is aging a disease in and of itself?
Yeah.
If you can summarize, because that was a really in-depth discussion, but what your thoughts are.
Sure.
there.
I mean, my general take on that is that's the wrong question.
Okay.
Not because it's not an interesting question. It is an interesting question, but I think it really tends to polarize people because some people believe that we need to call aging a disease because that will allow FDA to approve drugs for aging. That's a myth, and we could get into why that's a myth, but that's a wrong approach, I think. But some people also think we need to call aging a disease because then maybe insurance companies will pay for interventions that modify aging. That's important. I don't think simply calling aging a disease will have that effect, but that conversation needs to happen. But on the flip side, other people get very defensive. And if we call aging a disease, then every old person is sick, right? And I don't think we want to say that.
No.
We don't want to say once you get to 60, you have a disease, right? So I think the more important point that those of us in the field who try to communicate the importance of this research should make is that there is a biological process that underlies aging. We have learned a lot about that process. And one of the things we've learned is that it's modifiable, meaning we can do things to slow up or speed down the rate at which different animals and people age. And that shouldn't really surprise people when you point out lifestyle. We know things like a healthy diet, regular exercise, quality sleep, important human relationships, all of those protect against every major age-related functional decline and disease.
Totally.
And they do that because they target the biology of aging. They actually slow the biological aging process. And so I think if people can understand that, then you can get to the point where you can communicate the importance of continuing to study that area of research, because as we learn more about it, we're going to identify better ways to improve health, hopefully increase health span and lifespan, and importantly also do that in a personalized way. We can understand at the individual level, what do you need to do to have the greatest impact on your biological aging process to give you the greatest opportunity for a long, healthy, fulfilling life.
Yeah, I love that. And that's, if you're my patient, you've heard me say that a million times, but let's go into one of these potential pieces, which is rapamycin. So, and you know a lot about this one, but just give people an idea of like, where did rapamycin actually come from? We can keep this piece short. I know you've gone into depth before.
Sure. Yeah. I mean, rapamycin is a super interesting molecule. It was first identified from expedition to Easter Island, where they were sort of looking to understand, what is it about Easter Island that would, at least this is my understanding, that would allow the natives there to walk around barefoot and not get tetanus. They thought there might be something in the soil. So they went and collected soil samples, identified from the soil samples this molecule, which they named rapamycin. That's after Easter Island. So Easter Island, the native name is Rapa Nui. That's where the drug gets its name. And so they started studying it as a potential antifungal. And it turns out it's a very potent antifungal. And it does that because it inhibits a protein called mTOR They named the protein after the drug. mTOR stands for mechanistic target of rapamycin. And what mTOR is kind of a central cellular sensor of the environment, particularly nutrient cues, and it regulates cell division based on how much food is around. So when you treat cells with rapamycin, that inhibits mTOR, that turns down the cell growth signaling, and that causes the cell to stop dividing. That's why it's a very potent antifungal. Then people started studying it as a potential anti-cancer drug. It's useful against some forms of cancer, but it's not a widely useful cancer drug, largely because many cancers evolve to bypass that mTOR break. And once cancers have evolved to bypass that break, the drug's not going to work anymore. So how it actually got first clinically approved was as an organ transplant drug. Again, for the same mechanisms, when you get an organ transplant, right, your immune system will react against that organ, and it requires a lot of cell division and inflammatory processes for that reaction to happen. Rapamycin, again, very potent anti-proliferative, and it's also a very potent anti-inflammatory in combination with other immunosuppressants is historically pretty useful as an immunosuppressant drug. So it was first approved by the FDA, 20 plus years ago now, to prevent kidney transplant rejection, and then has been used for other types of organ transplant rejection as well as some other rarer indications. But we know a lot about rapamycin in human use because of that FDA approval and clinical use. Now, if you want me to talk about how we got into it on the aging side, I can tell you that story as well. It's a pretty interesting story.
I actually do. I want you to go into that because, where you are, we're talking about transplant. So it's like, how did we ever get to aging?
Yeah. And it was, again, sort of a happy accident. And I feel very fortunate that I was able to play a role in that happy accident. So this was really right around, early 2000s, maybe 2002, 2003. 3 different research groups, actually 4 different research groups in 3 different organisms. So I was working in yeast along with Brian Kennedy. A couple of labs were working in C. elegans and one in flies, all independently converged on mTOR as a potent regulator of lifespan in those organisms. And in our case, we were doing what we call an unbiased genetic screen, basically just looking one by one at different strains that were all lacking one gene. And we got lucky that in the first 500 or so we looked at was TOR in yeast. And when we knocked it out, they lived longer. And so I didn't know anything about rapamycin at this time. I was a postdoc. So of course I went to the literature and I said, well, what is mTOR? And I was like, okay, there's this drug, rapamycin, that inhibits mTOR. We had knocked the gene out and seen lifespan extension. I thought maybe the drug would also extend lifespan. And it did. And then, like I said, these 3 other groups, all right around the same time, we all published high profile papers. And I think the fact that we all independently got there, so there was sort of this independent replication accidentally built in, and the fact that this was happening in 3 different laboratory organisms separated by billions of years of evolution, we all got really excited. We're like, okay, this seems really important if it's fundamentally conserved over that much evolutionary period. And then a few years later, the mouse interventions testing program tested rapamycin as one of the drugs that they were looking at to see whether it could affect lifespan in mice. And in 2009, they published a paper showing that indeed you could treat mice with rapamycin. It would increase their lifespan. In that study, it was about 15%.
Okay.
But one of the important features of that study was they showed you didn't have to start at the very beginning of life. You could actually start the treatment in middle age. These mice were like the mouse equivalent of a 60-year-old person and still get large benefits. And so that was published in 2009. I'll just take a moment to say, I look back now at that paper, and I think that was really one of the most important papers and I wasn't involved in it, that has happened during my career, precisely because they showed this middle age effect. That was really the first time anybody had definitively shown you could start a treatment in middle age and get this big effect on lifespan. And we now know that there are multiple things where you can do that, but it kind of changed for me, and I think for many people, the way I thought about aging. And it's this more dynamic process that we can manipulate even late in life. And I think with rapamycin in particular, it doesn't seem like there's a point that's too late. At least nobody has shown that. There might be, but it doesn't seem like there's a point in life where it's too late, at least in laboratory animals, to get benefits.
Does the absolute effect get less and less?
It's a little bit
later?
unclear. Yeah.
Okay.
So with caloric restriction, and we haven't talked about caloric restriction, I'll just say historically that's the gold standard for an intervention that increases lifespan in laboratory animals. And I want to be clear, I don't recommend caloric restriction for people. We could get into that if you want to. But in laboratory animals, that's kind of the gold standard. The biggest effects that people have been able to achieve have been with severe caloric restriction. With caloric restriction, the effect definitely tails off as if you start later in life. With rapamycin, it might a little bit, but it seems like you can get most of the benefits starting pretty late in life.
Interesting.
Yeah.
So with caloric restriction, just so we have something to compare to, what is the lifespan extension in animals?
So the biggest that I'm aware of is about a 60% increase in mice. And we should stick with mice because when you get to the very short-lived animals, things sort of get conflated. Yeah. But in mice, it's about a 60% increase in lifespan from about 60% caloric restriction. And that's an experiment that was done in the 1980s, early 1990s. Okay. With rapamycin, I think the best that's been seen is about 30%. And again, sorry to keep getting into these details, but I think it's important. You have to be really careful with percent effects because, and both of those studies I'm talking about, the mice lived a really long time.
Right. You're looking at the controls all the time, right? Is that what you're getting at?
Right. Exactly. So in the caloric restriction study, the longest lived mice were, I think it was about 1,600 days. In the rapamycin study, the longest lived mice were about 1,400 days. In general, a typical wild type mouse strain, the average should be about 850 to 900, and the longest lived mice, will top out somewhere around 1,200. So we're talking pretty big effects. But it is important because you'll hear a lot of people throw out numbers like, berberine increased lifespan by 60%, and that's because their controls were so short-lived that the treated group actually ended up right where the controls should have been. That happens a lot.
Did it even have an effect?
Exactly. That happens a lot in the literature, and those things almost always are not reproducible.
Yeah. Is this what happened with resveratrol? We can kind of...
No, resveratrol is a different story. So we can talk about that if you want to, but maybe save that because that's going to be off on a tangent. Resveratrol never increased lifespan in mice, in wild type mice on a regular diet. And we'll just leave it at that.
We'll come back to that one.
Okay. So anyways, what we've learned since the 2009 study on rapamycin, I think has continued to increase confidence that this molecule, again, at least in laboratory animals, is not just increasing lifespan, but also broadly improving a variety of health span metrics. There's a long list of tissues and organs where mice treated with rapamycin have shown better function as they get older. And in a few cases, it's really interesting. You can actually take aged mice where there's already been a decrease in function, start treatment with rapamycin, and within 4 to 8 weeks, see functional improvements in those tissues and organs. And so that to me really, I think, sets the stage for clinical trials in people where you can take populations of people, maybe not diseased, but where there's a functional decline and potentially see improvements in function in a relatively short time frame. So rapamycin looks really promising on the preclinical side, the laboratory animal side. And it's, I've talked about this a lot. It's very frustrating that the translation has happened so slowly. Veronica Galvin and I wrote a paper, I don't know, it's probably 2018, and this was, after 10 years trying to get a clinical trial going for rapamycin for Alzheimer's disease. Like there's dozens of papers showing that rapamycin in laboratory animals can delay or reverse declines associated with Alzheimer's disease. Still hasn't been a definitive clinical trial in people, although a couple of studies came out recently showing in people who are ApoE4 carriers. Again, this is getting a little technical, but that's the greatest genetic risk factor for Alzheimer's disease. So these are people who are carriers. Even short-term treatment with rapamycin seems to improve hippocampal brain volume, caudate nucleus brain volume, and cerebral blood flow. So we're starting to get hints.
Sorry to interrupt. Are these people with ApoE4 symptomatic at this point?
No,
are they diagnosed?
Pre-symptomatic.
It's pre-symptomatic.
Yeah, at least pre-symptomatic in terms of cognitive function. I don't think there were enough people in the study, and this is getting outside my area of expertise, to know whether the brain volume had already declined.
Yeah.
For people who are in that space, they might be able to answer that question. I'm not sure, but they didn't have mild cognitive impairment.
Right. Have there been any studies on mild cognitive impairment with rapamycin?
Not that I'm aware of.
That's a bummer.
It's more than a bummer. It's irresponsible. It's just insane. I mean, I really am angry that this hasn't been done. Like, again, I feel very fortunate to be in a space where I know the literature. If somebody who I loved was diagnosed with Alzheimer's disease, I'd have them on rapamycin right away. This should have been tested a decade ago. It hasn't been tested. And the Alzheimer's field dropped the ball. Like, that's all I have to say on it. It should have been done.
It's super frustrating because in something like Alzheimer's, it's not like we have the home run treatment, and it would be unethical to not give them that, right? So it's like,
not only that, but this is an FDA approved drug. I mean, and again, the cynic is going to say this hasn't been tested because there's no money to be made because it's off patent.
Yeah, but anybody who has a loved one with Alzheimer's disease, I don't know, me personally, I'm ApoE4 carrier, so it's something that I'm definitely
right. So I can send you the links to the papers, and you can put them in the show notes if you want. But you should take a look. Again, small studies, and this is part of the challenge, right? Is I'm not saying these studies are definitive by any stretch of the imagination. Of course. We don't have the definitive studies because the Alzheimer's field has dropped the ball. So this is kind of the best we can do, but it looks intriguing and about as compelling as small studies can look to my eye. And this is like a really easy question to answer for brain volume, right? You just give people MRIs before and after. Like, it's not hard. So again, questions should have been answered years ago. Could be answered now in less than a year. Maybe somebody will step up and do the study.
Almost as frustrating as insurance.
Yeah, right.
Almost.
Actually, I would say it's worse because
it's worse. I agree.
If anybody's ever had a loved one go through, dementia, it's just crushing. Yeah. So anyways.
We won't, I could keep going, but totally. Okay, you talked a little bit before. I want to rewind a little bit in terms of mTOR. Obviously, rapamycin is going to inhibit mTOR, but what are things naturally that are going to either push mTOR or inhibit it? Yeah,
and I have to be a little bit careful here. It's easy to be imprecise in the way we talk about mTOR, and people get confused, right? So again, mTOR is one of the major gatekeepers for cell growth and cell division. So when mTOR activity gets turned up, that promotes cell growth and cell division. Now, in some tissues and organs, you want cell growth, right? Lean muscle, for example, right? So mTOR has been talked about in the exercise physiology world or the muscle biology world for a long time because it's important for muscle growth. And if you can go buy supplements, they're like mTOR activators, right, to build muscle. But in other tissues and organs, you don't want hypertrophy. You don't want mTOR to get turned up, and mTOR is necessary for cancers. So things that boost mTOR in general are going to be nutrient cues. So if there's a lot of nutrient cues around, that tends to turn up mTOR. And the one that's been most well documented, or the group that's been most well documented, are branched chain amino acids, leucine in particular. A lot of the mechanism is known there. I think we now know that other types of nutrient cues, sugars, fats, can also affect mTOR directly or indirectly. So in general, though, anything that the body senses as nutrition is going to be a signal to grow and reproduce. And evolutionarily, that makes a lot of sense, right?
Yeah.
You can think back, every organism that's ever existed has had to face a fundamental decision. Is it, from an evolutionary perspective, a good time to have babies? And if there's not much food around, it's a really bad time to have babies because you can't feed them. So mTOR kind of makes that decision. When there's not much food around, that turns mTOR down. And so the things that are going to reduce mTOR signaling are things like fasting. So there's not a lot of amino acids, not a lot of sugar around. And so that's all true, and that's correct. I think where people get confused is with this idea that, fasting or rapamycin is going to cause you necessarily to lose muscle, right? The context is really important. Certainly, prolonged fasting, especially fasting without doing any sort of resistance exercise, is going to cause you to lose muscle. Probably if you took a high enough dose of rapamycin, you would lose muscle. But short-term fasting, moderate doses of rapamycin. I don't know of any literature suggesting that rapamycin in people causes loss of muscle or even age-related conditions like sarcopenia that are associated with loss of muscle. I don't know of any evidence to support that. And in fact, the little bit of evidence that we have now suggests rapamycin is probably protective against lean mass loss. And the mechanisms there aren't very clear. I suspect they involve a reduction in chronic inflammation, but and maybe changes in mitochondrial function, but I don't really know. One of the challenges with mTOR and rapamycin is because mTOR has this central role in cellular physiology, it connects to almost everything. In fact, you could put up the diagram of the 12 hallmarks of aging, and you can find connections between mTOR or rapamycin and all 12 hallmarks.
Yeah.
Whether they're direct or indirect or 4 steps removed, it's this complicated network that I think we still don't have a very good understanding of.
And when you're talking about the literature in terms of you haven't seen the reductions in muscle mass with mTOR use in humans,
Right.
Are you looking at healthy humans? Or are you looking at organ transplant?
Both.
Because I do wonder,
Yeah.
like, is there a possibility that this is, if you're taking rapamycin, you're likely resistance training, so it's almost like a healthy user bias?
Yeah, that's a good point. So again, I'm not aware, and it might exist. I've looked and haven't seen it. I'm not aware of any data in organ transplant patients that organ transplant patients who are taking an mTOR inhibitor, and we didn't get into this. There are a couple of other versions of rapamycin that are also used in organ transplant. So organ transplant patients taking an mTOR inhibitor versus organ transplant patients not taking an mTOR inhibitor, that there's any difference in muscle mass.
Yeah.
Could be that it just hasn't been studied enough, but I'm not aware of any evidence to support that. And then in people using rapamycin, what we call off-label, again, if anything, there's a protective effect, but again, that data is not super solid. There was one study, I don't know if it's been published yet, but the data has been presented at least as a preprint and online of a sort of decentralized clinical trial. It was called Pearl. It was done by Ageless RX, where they actually, we could talk about why, but they accidentally used a low dose of rapamycin, about 30% of what they were shooting for. That had to do with using compounded rapamycin that doesn't have very good bioavailability. But and there they actually saw statistically significant improvements in lean mass in women who were taking rapamycin compared to the placebo. So again, is that gold standard? No, but suggestive. So I would say right now, I'm pretty confident, and I mean, we can talk about N of 1 stories. I can talk about my stories, but I'm pretty confident that rapamycin doesn't, at least at the doses we're talking about for off-label use, does not negatively impact lean mass and might actually be a little bit protective for preserving lean mass, especially when you're losing weight. So that's kind of my take on the data, but recognizing we don't have gold standard data. So it's a little bit of a guess. Yeah.
We both agree, you knowing much more about this than I do, that there's not enough data yet to say we know everything about this drug in terms of longevity.
We don't know anything about it for longevity in humans, I would say.
And so, but you've decided to take it personally. You just said that, so I'm going to repeat it. So you're taking it personally, you're taking it cyclically.
Yep.
And so when you did your risk benefit ratio of should I take this, should I not take this drug, when you're looking at human studies, or maybe you based it mostly on the animal studies, kind of lead me through that thought process, because this is exactly what I do with patients, where I'm like, here's the risk, here's the benefit, here's why I'm taking it or why I'm not taking it, here's why I think you should take it or shouldn't take it.
Right, sure, happy to share. So, and I will say, I think my own personal views on this sort of risk reward analysis also have changed over the last 10 years.
Great.
If you'd asked me 10 years ago, I'd probably be like, no, nobody should take rapamycin. We don't know enough, right? So in my case, this was probably like, I don't know, early 2020. So it was before the pandemic had really hit. I was having a lot of shoulder pain in my right shoulder. And it was progressive over a few months. And I kind of ignored it. I was a pretty typical, I was probably 50 then, 50-year-old guy. I was like, oh, it'll go away. It'll get better. And it got to the point one day where I tried to go across the street. We have a park across the street from our house, and throw a ball with my youngest son. And I couldn't make that throwing motion. I couldn't do this because it hurt too much. And I'd be like, oh man, Jace, I'm sorry. I just can't do it. And that was like the first, this is really bad. I'm getting old.
Yeah, I feel that.
Right? Yeah. It was really traumatic for me, but it was also the sort of the spur where I'm like, okay, I convinced myself, a torn rotator cuff, right? That's the only thing it could have been. So I go to my primary care doc and I'm like, doc, I can't sleep. I can't throw a ball with my kid. I need to go see a specialist and get surgery and get this fixed. And he's like, no. You should go to physical therapy first. And I'm like, all right. So I went to physical therapy, made it worse. Went back to him like 6 weeks later. I'm like, okay, I want to get into the specialist. I need surgery. Yeah. I need this fixed. Yeah. So he gave me a referral. Fortunately, I was able to get in. And this was right in the pandemic. So I'm surprised I was actually able to get in as quickly as I was, but I was able to get in quickly. And within 10 minutes, the guy's like moving my arm around and doing stuff. And he's like, you don't have a torn rotator cuff. You have frozen shoulder. Actually, he called it adhesive capsulitis. And I'm like, what's that? He's like, it's frozen shoulder. It happens, in people your age. And I was like, oh, fuck you. But he's like, it's more common in women than men, but I see it all the time. It's like, I can give you a shot into the joint. I don't want to do that because that can cause cartilage damage. It's like, I want you to go back to physical therapy and it might go away in a year. That's what he says to me. Might go away in a year.
It might go away in a year. You're like, yay.
And I vividly remember, I like go out to the car and I'm angry and I'm depressed. And I'm like, I can't do this for a year.
Yeah, totally.
I can't do it. And then I start thinking to myself, it's just like this age-related inflammatory condition. I know this drug. And by this point, we'd done a couple of small clinical trials in dogs. The research had gotten to the point where I knew rapamycin was very potent at blunting age-related chronic inflammation. And I'm thinking this is an age-related chronic inflammatory condition. It's sterile inflammation. I don't have an infection. It's just my own body inflaming the shoulder capsule. I don't have anything to lose. Like I was sure I could do it safely. Enough people have been taking rapamycin at 6 or 8 milligrams a week. I was sure I could do it safely. And by that point, from work in my own lab, we knew that between 4 and 12 weeks was enough in mice, and there was a little bit of data in people to see the anti-inflammatory effects. So I thought, okay, I'm just going to do 8 milligrams a week. I'll do it for 12 weeks. Probably won't work, but I got nothing to lose at this point. So that was really my risk-reward analysis.
Okay.
And within a few weeks, I had noticeable decline in pain, and just really within probably 3 weeks, noticeable decline in pain and some improvement in range of motion. And by the end of the 12 weeks, I was like 95% back.
Fascinating.
Yeah. So again, could it have been placebo effect? Sure. I can't rule it out. But I mean, in my situation and in people I've talked to who've had frozen shoulder, like we all get it. It's so painful. Very unlikely, I think, that it was placebo effect. And the biology is just too plausible given what we know about how rapamycin works. It really makes a lot of sense biologically that it probably was at least partly due to the rapamycin. Yeah. So that was the first time I did it. Like I said, I did it for 12 weeks. And I've done it, off and on since then. Usually for 12 weeks at a time. I played around with dose, done 6 mgs, I've done 10 mgs, never noticed any real side effects. The one thing, and again, this could be placebo effect, but it happens every time. I do a lot of resistance training and I get pain in my wrists and my elbows in particular. That goes away every time I start taking rapamycin.
Interesting.
So again, it kind of makes sense with chronic inflammation.
Potentially.
Could be placebo effect. The last thing I'll share, and again, I like the first time somebody said this to me, I was like, no freaking way. This is just BS. But somebody was like, every time I take rapamycin, it's not like I'm trying to lose weight, but if I try to lose weight, it's really easy on rapamycin. And that's been my experience too. So I started rapamycin, was it January of last year? So this was in January 2024. And I was about 195 probably. I think I was probably, I have to go back and look at the DEXs. I've showed it on the podcast, but I was probably around 21% body fat at that point. And over the next 3 months, like I wasn't like trying hard to lose weight. I was just really conscientious about what I was eating. And I was losing weight, but it was really easy, like really easy. And I get hungry all the time. My wife is like, you're hungry all the time. It was really easy when I was on rapamycin. But I preserved my lean mass. So I lost like 10 pounds, didn't lose any lean mass over a period of 6 months. Yeah, this is measured by DEXA. Yeah. So anyways, I don't know if that's real, but like I said, I've heard people say that. And I was like, that makes no sense.
Right. But you experienced it.
I did experience, and I just started rapamycin in January of this year, and the same thing.
Okay.
So again, I haven't lost 10 pounds, but the same sort of perception that, it's easier to eat clean, maybe. Yeah. And I eat pretty clean. Nick can confirm off camera.
I'll be checking.
He's like, I hate traveling with Matt. All we do is eat salads.
Okay, so I want to go back to the frozen shoulder and just kind of like push a little bit in terms of, obviously this is an N of 1, so we're not like saying, okay, this is the cure for frozen shoulder, but
let me sorry to interrupt you, but this raises another thing I'm really frustrated about, because I've talked about this a lot, and I've talked to people, who treat frozen shoulder. Why the hell hasn't anybody done that clinical trial? That's trivial.
I mean, yeah, we could say that for a bunch of things, right? In terms of we need to do a lot more trials. But
sorry,
do you think, it's okay. No, it's okay. So Do you think that you were doing your own PT alongside of this rapamycin? Because obviously you were taking it. I'm sure you were tracking some things. You're a scientist. Like there was more attention on this because you wanted to see, am I getting better or not?
Yeah.
Do you think that there could have been other variables that could be contributing to this? Do you feel like it was majority rapamycin? Obviously,
Right.
we're kind of just postulating.
Right. Yeah. No, of course. And I mean, this is why I even still say, like, I can't rule out placebo effect.
Yeah.
It absolutely could have been. Placebo effect is real.
Real.
So certainly that's a possibility. I'm as convinced as I can be that the rapamycin played a big role simply because of how long I'd been dealing with it and how fast it resolved itself. Which again, it's the only time I've ever had frozen shoulder, so I can't compare it to like, prior experience. But from talking to lots of people who've had this condition, it doesn't seem like it's the kind of thing that resolves itself that quickly. In many people, it will eventually resolve itself, but it seems like it's a much more gradual thing. And I hadn't had it for, many people will have the symptoms for a year or more before it sort of resolves itself. So I'm pretty confident that the rapamycin played a big role. And again, the biology, just given what I know about how rapamycin impacts chronic inflammation, it makes a lot of sense that would have that effect.
Yeah. And one of the most common side effects of rapamycin is going to be like mouth ulcers, right? Experiencing
I've never
personally?
had that. Yeah.
Nothing.
That seems to be very individual. And our data of people using rapamycin off-label puts it at about 15%, but we don't really have an understanding of why some people experience it, why some people don't. Some people will even experience the first time they try rapamycin, then they'll stop, then they'll try it again. They don't get the mouth sores. I will say, in the organ transplant patients, these can become very severe ulcers in the mouth. The people using rapamycin off-label, it doesn't seem to be those sorts of severe ulcers. It's more like a canker sore for most people.
Yeah, and the dosing is going to be different in terms of those two groups.
Oh yeah, absolutely. We didn't talk about the dosing, but in organ transplant patients, so there's two ways the dosing is different. The cumulative dose in organ transplant patients is higher in the sense that, again, this is my understanding. I'm not an organ transplant doc. First of all, there's a loading dose, which is pretty high. And then people will get to this steady state maintenance dose, which I think is usually maybe 3 milligrams a day, but it's given daily. People who are using rapamycin off-label, the most common dose people are taking is 6 milligrams, but it's dosed once a week.
Right.
And that has pretty significant differences in the levels of rapamycin in the blood and the way that mTOR is inhibited in different tissues and organs. So if you take it once a week, your blood levels, which we can measure, there's a lab test that will measure this through LabCorp, will spike after a couple hours, and then they'll kind of come down. And it seems like the kinetics of clearance is pretty individual, but in some people, like for me, I've done the sort of time course, I'm below detection limit by the third day out. So I spike, and that's at 8 mgs, and then I'm down.
So then why 1 week?
Yeah. So the idea is, so first of all, observationally, just looking at the side effect profile, it seems to be the case that that it's really the trough levels, the bottom levels that are driving most of the side effects. There was actually a really solid clinical trial done by Joan Manick. I want to say the paper came out in 2012. They used a derivative of rapamycin called everolimus, and they tested people at, I think it was 1 or 2 mgs a day, 5 mgs once a week, and 20 mgs once a week. And what they saw was that the 5 mgs once a week, and even at the 20 mgs once a week, the side effects were dramatically reduced compared to the daily dosing. In fact, at the 5 mgs, it was no different from placebo. So it's thought to be that those trough levels are driving many of the side effects. You can come up with sort of speculative biochemical mechanisms. So it turns out, this is getting a little bit in the weeds, but turns out there are 2 complexes that mTOR functions in, named mTOR complex 1 and mTOR complex 2. So rapamycin inhibits complex 1. It does not directly inhibit complex 2, but chronic inhibition of complex 1, like daily dosing of rapamycin, will have off-target effects on mTOR complex 2. If you allow those rapamycin levels to bottom out, you can avoid those effects on mTOR complex 2, and some people believe that's driving the side effects. So they're sort of hand-wavy, maybe a little bit better than hand-wavy explanations for why once weekly might be superior, at least for side effects. And that's what the off-label use community, such as it is, has gravitated to. And there are sort of weird cultural reasons for that. There was one doctor who sort of was out early prescribing rapamycin, and he started with 6 milligrams once a week. And that's what a lot of people started using. And that has sort of stuck, it seems like.
Okay, so I want to do one more example, if you'll stay with me here, where we could even use myself as an example. But if we're doing risk-benefit ratio, I don't have frozen shoulder, I have nothing acute, kind of how do you think people should start to think about this, knowing like this is not medical advice, you got to talk to your doctor, let's take off all liability there, but just like an interesting thought process of how should we start to weigh this right now, knowing that we don't know a ton about this drug?
Right. So I would say there's a couple of cases where I would think more deeply about rapamycin and maybe gravitate more towards the reward side. And so one would be, you mentioned ApoE. We've mentioned ApoE. So ApoE is, again, ApoE4 is the largest genetic risk factor for Alzheimer's disease, as well as cardiovascular disease. It has a big impact there as well. So if you have two versions of ApoE4, you're at like 15-fold higher risk. And if you have one version, you're at somewhere between 5 and 6-fold higher risk. Important to say, you can mitigate those risks with lifestyle. That should be where everybody starts. But I think if you're a carrier, and especially if you're homozygous, that would tip me a little bit more towards the reward side.
So you have both.
You have 2 copies of E4. Yeah. So that would help me weigh that sort of calculation. And then age is the other big one. So I think that there is a clear, we all know there's a clear increase in risk of a bunch of different diseases as we get older. And I think that there's the potential, given what we know about rapamycin, its effects on the biology of aging and what's been seen in laboratory animals, that it could be protective, at least for some age-related diseases in people. So the older you are, in my view, that also starts to tip that calculation towards the reward side. So you can also think about like, what are the real risks? So far, and again, this is where, unfortunately, we don't have the long-term studies, especially any long-term studies of people using rapamycin off-label. The risks I would think about, and the ones that I think are probably real, certainly in organ transplant patients, would be immune suppression, right? That's how it's used in organ transplant patients. So are you going to be at higher risk of infections? The data for off-label use so far suggests, if so, it's probably not a very big effect. So there might be a slight uptick in risk of bacterial infection. There seems to be some protection against viral infection. And again, there's some mechanisms there that make sense based on what we know about the biology. The other place you might think about are lipids and glucose regulation. So again, in organ transplant patients, sometimes you see hyperlipidemia, so high lipids in the blood. Sometimes you see a pseudo-diabetic state, so reduced insulin sensitivity, higher insulin resistance. Again, in off-label use, I haven't really seen that. But I would say anybody who's taking rapamycin off-label should get those tests. Those are easy,
just
right?
now.
Yeah,
that's
right. And if you see your biomarkers go in the wrong direction, you can adjust. So those would be the risks that I would really think about and pay attention to. Again, I've been using it cyclically. It's funny. I'm much less scientific when it comes to my own sort of, biohacking approaches than I am in my professional life. But I've used it cyclically, and typically it's 3 months. Although last year I did 6 months because it seemed to be having interesting effects, and I was like, okay, I'm going to keep going for another 3 months. So
you're doing 3 months on, and then
some period of time off. This is what I mean by not being particularly scientific. When the aches and pains start to come back, or when I feel like I want to try a new experiment.
Ballpark, you're taking a week off.
Roughly 3 months on, 3 months off, 3 months on, 6 months off, something like that.
Yeah. Okay. And when we talk about the immunosuppression potential that we're seeing, any concern, because we talked about cancer before in terms of, could it actually be beneficial? But
good question.
When you're looking at that, what are we thinking?
So I think a couple things to say there. I very much believe that aging to some extent is an acquired autoimmune disorder. And what I mean by that is, we know in every mammal, at least, with age, there is a dramatic increase in what we call sterile inflammation, right? Activation of the immune system against stuff it shouldn't be activating against. One of the consequences of that chronic inflammation is that the immune system can't do its regular job. One of those things is fighting off infections. Another is surveilling cancer. So again, this is a little bit speculative, but there's a lot of evidence to support it. I believe that this increase in sterile inflammation is actually one of the driving factors that causes an exponential increase in cancer with age, because we lose that cancer surveillance. So your question was, might rapamycin actually be a risk for increased cancer because you're suppressing immune function? I think in organ transplant patients, that'd be the first place I'd look. And people have done these sorts of, large scale studies of organ transplant patients and asked, is there a difference in organ transplant patients taking mTOR inhibitors versus those not taking mTOR inhibitors? And they've looked at a bunch of different cancers. And again, my understanding, and there may be differences in different studies out there, as there often are. My understanding is when you kind of look at that whole picture, for all cancers except for blood-based cancers or immune cancers, there's a slight decrease in risk with organ transplant patients taking mTOR inhibitors. But in the blood-based cancers, there's a slight increase. So net, probably not a big effect, even at those high doses. Yeah. And again, those are people taking strong immunosuppressants in addition to the mTOR inhibitors. Yeah. In off-label use, we don't have any data. Yeah. So my intuition is the anti-inflammatory effects from chronic sterile inflammation are probably going to be net beneficial for cancer surveillance. But the real answer is we don't know.
We don't know.
Yeah.
Yeah. And you're also, this is down a different rabbit hole, but it's who is taking this, right? So if you have somebody that already has a ton of inflammation, you may be dramatically reducing their risk versus somebody that is completely healthy. Then do we want to?
And I will say, this is my sort of, anecdotal observations that it seems to me, and I've talked to a lot of people using rapamycin off-label. We actually published a paper last year where we collected data from more than 300 people who'd been using rapamycin off-label. And it seems to me that people roughly fall into two buckets. There are some people who take it and they have some gastrointestinal stuff and they just stop taking it. That seems to be a minority. But the people who stay on it, there are some people who say, I don't feel anything. I don't know. Didn't feel anything. Then there's some people like, oh my God, I feel so much better. I speculate those are the people who have high chronic inflammation. And it's just blunting that. And we all know if you're really inflamed, you feel like crap. So I think, and that you could say that was the same thing with my frozen shoulder, right?
Did you measure any markers of inflammation in yourself in terms of CRP, sed rate?
I wish I had. Again, this is one of those things where I'm fairly new to this sort of, tracking biomarkers world. I wish I had that data going back to my 30s and 40s, but unfortunately, no. And but there are people who have shared, their biomarkers on rapamycin. And I believe that as part of the Pearl trial, they did measure at least some of the common blood-based biomarkers. I don't think they've published that data yet, but we're starting to gather that sort of information. So yeah, it's still speculative at this point. And I will also say, inflammation, it's kind of a catch-all word. And so I'm using it obviously very loosely. I don't think we necessarily know exactly what the right inflammatory markers are to measure yet. Although again, lots of really great work being done on inflammatory profiles and changes with age. So I think the research community is getting closer to giving us a better picture of what we should be measuring.
Yeah. So beyond aging, when you're looking at rapamycin, any kind of things that we should keep an eye on in terms of other diseases that they're looking at? Yeah,
I think there's actually a lot of things where there's intriguing evidence for rapamycin, some of which are age-related, some of which are not obviously age-related. So the ones that I think there are now clinical trials happening that are interesting that I'm paying attention to, one is in the area of oral health. So you mentioned, it's kind of funny when I hear that I'm now an affiliate professor of oral health sciences. Like I know nothing about dentistry.
I read it and I was like, what the heck?
So how that came about was I had a graduate student years ago now who is a DDS PhD. So it's like an MD PhD, but a dentist. And he came to me, really smart guy, Jonathan Ahn is his name. He's now also at the University of Washington. And, he made the case that periodontal disease is an age-related disease, just like heart disease and cancer and, all the other age-related diseases we think about. And people who have periodontal disease are at higher risk for heart disease and dementia and diabetes. And so maybe there's a connection between the mouth and the body and the aging in the mouth. And so we did a study in mice where we showed that rapamycin, first of all, that mice develop periodontal disease naturally with age, and rapamycin could reverse that in about 8 weeks. And so now John is at the University of Washington, and now I've got this affiliate appointment in oral health sciences, where he's doing a clinical trial in people to test whether rapamycin can reverse periodontal disease. So periodontal disease is an age-related disease, but most people, for just stupid cultural reasons, we separate the mouth from the rest of the body when we think about health. But it's really interesting to think about the possibility that rapamycin might actually be able to have a positive impact there. So that's one I'm watching closely.
So this is a stupid question, but rapamycin has antifungal properties.
Yeah, might that have something to do with it?
Yeah,
don't know.
Or just like that mechanism.
It could have something to do with it. It's almost certainly not the entire mechanism.
Right.
So what we showed was, and you do see dysregulation of the oral microbiome with age, just like you do with the gut microbiome. So what we showed was that rapamycin in mice could at least partially restore. And again, these are very crude measurements, as you know, of how we measure the microbiome. But to the extent we can actually measure the frequencies of the different types of bacteria that are in the microbiome, it kind of reverted that signature back towards a more youthful composition. At the same time, it knocked down gingival inflammation, so inflammation of the gums, which is very common in people, and it caused regrowth of bone around the teeth, which is one of the clinically defining features of periodontal disease. So at that level, we could see all three of those going in the right direction. Now, is that because of local effects of rapamycin in the mouth or systemic effects? Still a little bit of an unanswered question. My speculation, and we've got a little bit of data to support this, is there's at least some systemic component, probably immune mediated, due to the effects of rapamycin, again, on immune function and chronic inflammation. So that's one. Yeah, so that's one. I'm really excited to see how that comes out. There are a couple happening. One's at University of Wisconsin, another one in New Zealand, looking at the effects of rapamycin on muscle function in the elderly. And in at least one of them, it's combined with resistance training. So, the question there is, and again, I think this is really important because there's been speculation, as we talked about earlier, mTOR is important for building muscle. Right. Will it have a negative impact? Will it have a positive impact? Will it have no impact? Hopefully we'll start to get those answers. So
and are you thinking mitochondrial emphasis there? Or
don't know. Could be inflammation obviously is super important with muscle.
Sarcopenia.
Yeah, exactly. So sarcopenia, as well as, you need some inflammatory signaling to build muscle. But if you have too much, that's going to be counterproductive. So yeah, it could also be metabolic. And we haven't talked about this. Mitochondrial disease is actually a place that's not obviously it's not age associated in the sense that, severe mitochondrial disease usually affects young children. So we published in my lab, this was, probably 2012 or so, that we could actually rescue a childhood mitochondrial disease with rapamycin in mice. It's a disease called Lee syndrome, complex 1 deficiency, completely unexpected at the time. And again, I wish I could say I was super smart and oh yeah, I know rapamycin is going to work. We kind of lucked into it. Excellent. But we could tell that story later. So we found that rapamycin could rescue severe childhood mitochondrial disease in mice. There's now a couple of studies, again, hasn't really been tested very much in people, but there have been a couple of case reports. One for a child with Lee syndrome, I believe, and another for adults with a different mitochondrial disease, an adult onset disease. So that's a place that I think is really interesting. So we know rapamycin affects mitochondrial function, but again, the wiring is super complicated and we don't really understand completely how that's working. I think ovarian failure, super interesting. So there's a study by Zev Williams and Yushin Su out of Columbia looking at the impact of rapamycin in women who are experiencing premature ovarian failure, again, based on mouse studies showing that rapamycin can rescue ovarian failure in mice.
Is the ovarian failure in mice looking at premature? I don't even know if that exists in mice, but are we talking about, so if you're listening, in menopause, you're going to have ovarian failure, right? And then you can have premature ovarian failure, and those are different things.
Different, but probably mechanistically overlapping.
Similar,
not going to be identical. Yeah, that's a good point. I believe I need to go back and look at the literature. My recollection is that people have looked both at normal age-associated declines in ovarian function and some models of premature ovarian failure, and those are usually chemically induced. So again, how much does that match, what's happening in the real world? It's hard to say, but I know people have looked at the regular age-associated declines in ovarian function. And actually, Yushin, who I just mentioned is involved in this clinical trial, just had a paper come out, I think it's in Nature Aging, where they showed, again, this is, I believe, was all in mice. There might have been some human data in there as well, that with age, in the ovaries at the single cell level, you actually see strong changes in mTOR signaling. Again, connecting the dots that there's dysregulation of mTOR biology in the ovaries as a function of age.
Yeah.
So
you're slowly convincing me to start rapamycin. I'm like, I don't have
well,
children
again,
yet.
it's very anecdotal, but so some women who I know personally have experienced interesting things in perimenopause if they start rapamycin. So
okay, say more. You have to, and I know
I can't say more. I have to be very careful. Other than, I mean, it all sort of lines up that rapamycin could potentially have, and again, that may not be something you want, right? Depending on where you're at, but could actually have effects at restoring some aspects of ovarian function in the context of normal aging.
Yeah, and I've said it a bunch of times, but if you're listening, like a lot of this we're talking about is empiric data. Like we're not talking about things that we know 100% for certain with repeated evidence, but it's interesting, and we need so much more research to really get an idea of like what out of these things are tried and true.
And fortunately, as we're discussing now, these clinical trials are starting. Now, it's important to say, and most people don't really understand this, all of these clinical trials are underpowered for efficacy. And that is mostly because to do a what people call a phase 3 clinical trial, that's kind of the last step if a company is going to get a drug approved for FDA approval. Those are very large studies. Huge. Very, very expensive. Nobody's willing to fund that size of a study for a drug that's off patent, which is what
there's not enough money.
Is. So these are studies that will give us a lot more confidence if they show positive effects, and you might actually get a statistically significant outcome, but they're not set up to really definitively answer the question, unfortunately. It's not the fault of the investigators. They can only do what they can get funded to do. So it's a tough road to get the answers that we all really would like to have. So we're all sort of operating on the incomplete data, and there's some guesswork involved. Absolutely. So the other one I want to briefly mention, this also I'm really excited about, is long COVID. So when we did this study of people using rapamycin off label, and we compared this to people who'd never used rapamycin off label. So again, it's not to the gold standard randomized clinical trial, right? This was all, survey collected from data from people after the fact. But we at least compared people using rapamycin to people who'd never used rapamycin. And we saw some interesting differences. But the one that I was particularly intrigued by was, this was in, we started the collection, I want to say mid 2022, maybe. So this was kind of right after we were coming out of the pandemic. So many of these people had been taking rapamycin all the way through the pandemic. And so we were able to ask, did you get COVID-19? Was it clinically diagnosed? How severe were your symptoms? Are you still experiencing symptoms, right? And so again, given the imperfect nature of the data, what we saw was there was no difference in risk of infection. So in other words, people taking rapamycin were at the same risk of getting COVID-19 as people who'd never taken rapamycin. But for those people who took rapamycin throughout their infection, and this was interesting, and this actually happened to me, some people, when they got diagnosed with COVID-19, stopped taking it. They're like, I better stop just until I get better.
Yeah,
right?
We don't know,
But when you compare the people who took it all the way through to the people who'd never taken rapamycin, there was a statistically significant reduction in the likelihood of moderate or severe outcomes. I don't remember the exact definition. I think moderate was like symptoms lasting more than a month, and then severe was had to go to the hospital, right? So that was interesting.
Very interesting. And with your controls in that group, were they age match peers or was it Gen Pop? Because that's like a huge.
I mean, we were fortunate in this. It was kind of all comers, but we were fortunate that the demographics lined up very well. There was no real difference between the groups. Other than there was a slightly higher cigarette and alcohol use in the rapamycin group, which I wouldn't have expected. But anyways, that's a story for a different time. But the other piece that was interesting was when you looked at the likelihood of prolonged symptoms. Again, we can't say it's not a clinical diagnosis of long COVID, but that's sort of what we were thinking, right? These are people who probably have long COVID. Significantly less likely in the people who took rapamycin throughout their infection, regardless of whether they stayed on rapamycin until the time of the survey. So that suggested to me that there might be a use case for rapamycin either during severe COVID infections or for long COVID. And so now there's a group out of Mount Sinai that has been funded to do a clinical trial of rapamycin for long COVID. So I'm really excited to see what happens there. I've also thought for a long time that Lyme disease may be another place because I think there's this sort of chronic recurrence of inflammation that drives some of these, syndrome-like conditions. And rapamycin might be beneficial there. I've heard some anecdotal reports for Lyme disease, but I've never seen a dedicated study on that. And then I'm speculating wildly, but this is something I've thought also for a long time is traumatic brain injury. So again, we know that there's an inflammatory component there. There's some mouse data for rapamycin with not just traumatic brain injury, but and again, I don't know the details of how these studies are done, but they like blast whole animals with sound waves or something to cause some sort of trauma. And there's some evidence there for rapamycin being beneficial. And then these new studies I mentioned earlier on changes in hippocampal volume. We know with traumatic brain injury, there's a decrease in hippocampal volume. Very easy to measure. You could test whether rapamycin could possibly restore that. And again, I think it's an interesting question. If there is an effect, would you need to do it acutely, or could you maybe even get benefits months or years down the road? Yeah, I am super intrigued by that. I would love to see somebody do that. I'd love to help out. If anybody's listening and you're interested, I'd love to be involved in helping to do that study.
I love that. If you could design one study with rapamycin right now.
Have to pick? Come on.
I'm just curious. It's more of a curious thing.
I think I probably would gravitate towards the long COVID study.
Over Alzheimer's.
Because I think we're more likely to see an effect quicker.
You'd know an answer.
Yeah. And because that may because first of all, I think there are a lot of people who still, are suffering with these persistent symptoms, right? That have a big impact on quality of life. If we're able to see an effect there, I think that would open the door maybe for some of these other things like Lyme disease or other syndromes. And I suspect, again, this is speculative, but I suspect that there are other types of conditions that result from persistent viral infections that just sort of get classified as chronic pain or chronic fatigue.
Yeah.
And so I think that if they share this recurrent or persistent inflammatory state and rapamycin is useful there, then this is, again, total speculation. I wonder if one treatment with rapamycin would be enough to kind of reset the system. And if so, that's great, because then it's a cure, right? Yeah. But even if you had to do it, 3 months out of every year, still could have a huge impact on quality of life. And again, we alluded to this before. It's been my experience that, again, there's some people who take rapamycin like, I don't feel anything, but the people who feel it, they really feel it. And they're like, oh my God, I'm never coming off. So if we can find those people and identify what is it about those people, I think there's some opportunities there.
Yeah, what are we seeing and changing?
Yeah.
And
but I have to say, if I sat here and thought about it for another 15 minutes, I'd probably change my answer.
Okay.
So
we won't hold you to it then. Bringing up the viral thing, it's come up in my head a couple of times, so I'll share it out loud. But when you look at Alzheimer's and even you look at cancers, right? Like there's viral risk factors for all of these.
Right.
Not all of these, but many conditions like that in terms of like herpes simplex virus, which is so widespread, and the implications for Alzheimer's. viruses and cancers can be, triggers or risk factors as well. And so if there is this antiviral component, like that's one thing, but it doesn't seem like it had an antiviral component with COVID in terms of getting the infection. I know small sample size.
Well, you wouldn't expect, let me reframe that a little bit. So one thing we know is that at least in some situations, rapamycin can boost what people call antiviral gene expression. So genes that are involved in the response to viruses. So in that case, you wouldn't expect a change in infection risk, but you might expect an improvement in outcome, which is to the extent that data is what it is, that is what we saw. But again, I don't, my sort of, I'm again not an expert in immunology by any stretch of the imagination, but my sort of non-expert guess for why we see these viral connections to so many different conditions is that it's really that persistent exposure to viruses, and we're all exposed to tons of viruses throughout our entire life. They can get into our genomes, they can be re-expressed. That happens with age. So we know that with age, because of epigenetic changes, there's an increase in dormant viral expression that drives inflammation. But there are lots of things that drive chronic inflammation. So again, if we think about the hallmarks of aging, these 12 hallmarks of aging, and that's no magic number, there's probably 54, but we've only identified 12. Several of them are what I would call upstream of inflammation. So DNA damage can cause inflammation. Mitochondrial dysfunction can cause inflammation. There's a bunch of these things, and viral persistent viral expression or re-expression of viral proteins and RNAs can also cause inflammation. Right. And so I think that's probably the connector. And one question is it the case that viral or bacterial, right? We know that with age, there's a higher likelihood that we're going to get inflammation due to the bacteria in our mouth and our gut and on our skin. So is viral driven inflammation the predominant form of inflammation with age? Is it in some people the predominant form? Is it the predominant form in long COVID or other conditions? Yeah. Almost certainly there. But I think with aging, we just don't know. Yeah. Like there's multiple things that could cause us to go down that path. And my guess is it's individual. Some people it could be viral, and some people it could be mitochondrial death, leaking mitochondrial DNA into the cell. So I think it's probably going to depend on you, your lifestyle, where you live, your environment.
Totally.
I mean, your diet, right? Again, sorry, I'm going off on a rant a little bit, but this is, I think, an interesting question. How much of chronic inflammation is driven by things in our diet that we haven't evolved to eat, right? That are now getting into our bodies. Our bodies are like, what the heck is that? Send the immune system to go take care of it. We just don't know.
We don't know. There's a big question mark.
Yeah.
Yeah. I think the answer to a lot of my questions here is we don't fully know.
That's kind of the nature of the science. There are some things we do know, and we can, and again, maybe that's I think an important take home message when we talk about health that sometimes gets lost. We spent all this time talking about rapamycin, which is super interesting and fun. But I think one of the things,
well and exercise. Have a good day.
This is I think where I was going to go is I would never suggest if people listening to this, first of all, I take rapamycin, so I have my own viewpoints on it. I'm certainly not suggesting everybody should rush out and take rapamycin. Yep. And I definitely would not say use rapamycin or any other, geroprotective intervention as a substitute for what we know works.
100%. That would be a bad gambling decision.
Right.
Okay, so let's talk a little bit about the Dog Aging Project. And if you guys are interested in aging or dogs, I would say listen to the podcast I did with Dr. Promislau, because we dive in deep to that. But I would love for you just to give kind of like an overview of what we're seeing so far with dogs and rapamycin.
Sure. So I wish I could tell you a lot. But unfortunately, we're still in the middle of the large clinical trial. So we've done two really safety trials to this point with rapamycin. One was a 10-week study, one was a 6-month study. And so in both of them, we saw no significant side effects due to the drug. And really that was the most important thing. Again, I think a lot of people maybe don't recognize this right away, but when you're talking about doing a clinical trial in people's pets, it's almost like a pediatric clinical trial. People think about their dogs the same way they think about their kids, right? So you really want to make sure it's going to be safe. So that was the most important thing, and we're confident that we can do this safely. We've not seen, as far as I know, we have not seen a single significant adverse event due to the drug in any of the studies. In the first trial, we also saw evidence for improvements in age-related cardiac function, specifically left ventricular function. And then owner reported improvements in activity and I'm not sure exactly what the right words are, but emotion maybe. So we didn't ask about this, but at every week we would send out a survey, mostly looking for side effects. We had a long list of side effects. Have you noticed this in your dog? But then at the end, we had kind of 2 throwaway questions. Have you ever noticed? In the last week, have you noticed anything that you would consider as a change negative with your dog, or have you noticed anything you would consider as a change that was positive for your dog? And so increased activity came out as being reported more with the rapamycin, the dogs getting rapamycin, than with the placebo. The owners didn't know, the vets didn't know, presumably
blinded.
The dogs
Yep.
didn't know. I call it triple blinded because owners,
Dogs.
vets, dogs, yeah. But then the weird thing was something like 30%. It was a high number, and none in the placebo group of the owners whose dogs were getting rapamycin said their dogs were more affectionate. And I was like, what the heck does that mean? And I still don't know what it means, other than, my speculation is there's a couple of things I could think of. One, obviously this could be a bias because the owners at least knew their dog was in a study, so they're paying a lot more attention to their dog. That wouldn't explain why it would be in the rapamycin group and not the placebo group. But another could be cognitive function. So again, we talked about Alzheimer's and other dementias where rapamycin, at least in laboratory animals, seems to have benefits. We know some dogs with age will develop dementia, and most dogs will show a decline in cognitive function. So I wonder if that's a sort of an owner's interpretation of an improvement in cognition, or at least a change in behavior in the dog. So anyways, that came out of the first study. And then the second study just wasn't powered enough to get any definitive data for endpoints, because what happened was we were kind of halfway through that study. We were shooting, I think, for 75 dogs in that study. And then the large grant got funded. This was like 2018. And so we knew we were going to move forward with the very large, the lifespan study. So we didn't want to take dogs out of that study to put them in the first one. So we kind of cut off enrollment. We gotten the answer we needed for safety. And so now we're in the middle of this lifespan study, which eventually will be 580 dogs, half placebo, half rapamycin. It's a 1-year treatment and 2-year follow-up. And so the dogs have to be at least 7 years old to come into the study. So with that demographic group, and they have to be more than 40 pounds. Again, this idea that big dogs age faster than small dogs. So with that demographic group, we should be statistically powered to detect a 9% change in lifespan. That's the primary endpoint.
Okay, so because I have a dog and I enrolled him in the dog aging project. But he's a puppy, so that's 1. And then number 2, he's only going to be 20 pounds.
Right.
But I was wondering about the weight, and it's because you guys need to have a certain amount of dogs pass away by the end of the study to be able to.
Right. I mean, it's sad to think about, but yes, if our primary endpoint is to see a change in lifespan, the only way we can see a change with rapamycin is if a significant fraction of the placebo dogs are not going to be alive at the end of the study.
Right. Okay.
And it's also worth saying, so lifespan is the primary endpoint, but then we have a bunch of secondary endpoints that are health span metrics. So things like cardiac function and neurological function and kidney function and, a bunch of different age-related diseases, trying to understand if we see, regardless of whether we see a change in lifespan, do we see any changes in a variety of different health span metrics?
I thought Dr. Promislav said dogs don't get heart disease.
So dogs, it's not as common in dogs. They get heart disease, actually. They don't get vascular disease.
ASCVD.
Right. But you see a lot of valvular degeneration, a lot of cardiomyopathies, breed dependent somewhat. There are some breeds like Doberman Pinschers.
Oh, right. Congestive heart failure.
60% will get dilated cardiomyopathy or something like that.
Okay, that makes sense. I don't know if this is kosher or not, but I'm going to ask you. So we met at a conference and I asked virtually every person I talked to there, are you on rapamycin or not, and why not? You were the only person that said you were on it. A bunch of people won't take it that are in the industry. Why do you think that is? Like, do you think it's just like in terms of you're more bullish and more apt to try things? Do you think that?
That's a good question. I don't know. So I'll say a couple of things. I know several of my colleagues who take it.
I mean,
so I don't know who you asked.
Totally. And that's a great point. I probably asked 10 people.
Yeah.
So
and again, I'm not trying to sell it. Like, first of all, I get no financial,
totally.
I've said this before. I wish there was like a rapamycin fund that I could invest in, but I get no financial benefit from rapamycin. And I'm not trying to say people should take it, but having said that, I've been surprised actually at some of the people who I found out do take rapamycin. But I will say, I think, again, 5 years ago, rapamycin was perceived as kind of edgy, right? Kind of dangerous. I think we've learned that off-label use of rapamycin, probably has very few risks, and the acute risks are kind of at the level of canker sores, right? So, or maybe high lipids in a small percentage of people. So manageable, I would put it that way. We didn't know that 5 years ago, certainly not 10 years ago. So I think that's changed a little bit. And I think in the scientific community, again, there's a fair amount of conservatism when it comes to medical and approaches to health. And, I'll say, because I've lived it, a lot of ignorance. Like most people working in, not about the science, but about health and about healthcare. Most people studying the biology of aging know almost nothing about clinical practice or how to, and they don't really take care of themselves. I didn't. I mean, I kind of did, but I have learned way more about my own health since I've gotten out of academia and actually taken a dedicated interest, and most scientists don't.
Yeah,
and I mean, it was always sort of ironic. It's changed a little bit, but still, you go to a conference, you probably saw this, right? You'll go sit through a session, and there'll be 3 talks about caloric restriction, and then you go out and it's coffee and donuts, right, or coffee and cookies, right?
Yeah.
So there's a not very much of a practice what you preach mentality still in the basic science world. And I'd be interested on your thoughts on, is that true in the clinical realm? Probably depends on which docs you're talking about.
Yeah, it definitely depends what conference you're at. But I did notice that at the conference that we met at, where it didn't seem, and this is like a broad generalization, where there wasn't an obsession with health across the field.
Yeah, and I mean, I'm not saying that there necessarily should be an obsession, but it would be nice if there were healthy choices for sure. So all of that is to say, my guess is in that audience, it's not an audience that is particularly attuned or attentive to their own health. And so it's just not on their radar. If they're not even necessarily, I mean, this isn't true for everyone. There are some people who are very much attuned to their own health. I remember like early on, Cynthia Kenyon was like eating a diet that was, very low in added sugars. And, so she was an early on adopter, but a generalization, most people in the scientific community are not really thinking thoughtfully about health span optimization in any real way. And so when they do that risk reward analysis, it's just coming at it from a different mindset.
Yeah.
So that really probably is part of the equation.
I think that you're right. I was at the gym every day at that conference, and there were repeat offenders.
Yeah. It is interesting though. Some of it's just perception too, right? I think if you ask people in the field, maybe not so much now, but 3 years ago, like how would you rank metformin and rapamycin in terms of risks? Most people would have said, metformin is way safer, right?
Interesting.
So it's just a perception thing. The data doesn't actually back that up, really, but it's a perception thing. And so it takes a while for perception to change. So all of that, I think, probably feeds into it.
Yeah. Okay. I want to talk a little bit about OptiSpan because we got to wrap up, and then I really want to do our rapid fire because it's the most fun part of this. Yeah. But OptiSpan is you tell me a little bit about it.
Yeah. I mean, I would define OptiSpan first and foremost as a healthcare technology company. So our goal is really about developing tools, technologies, protocols to enable at least a path towards health optimization for as many people as possible. And I think there are some things that if we sat down, we would agree on a lot of what that means. But I think there's a lot of confusion out there, which I know in terms of what's real, what's not, what can you actually do. And so we're working on a technology platform, but as part of that, we're also running a concierge clinical program and a corporate clinical program in this space, really with the goal of course, helping our clients achieve their best health span trajectory that they can, but also figuring out like where are the friction points, what works, what doesn't work, what's informative, what's not informative. If you could measure everything, what would you actually do that would actually help people? And so in our concierge program, we're working with a clientele where in principle, we can measure everything because it's pay out of pocket. And so we can work with them and say, okay, here are the things that we could measure. And we've learned a lot. We haven't yet talked about biological age tests, but that's one thing we've learned, right? Like the consumer-facing biological age tests don't work.
Yeah.
They don't provide actionable information.
Yeah. And you have a great podcast on this. So please, if you're interested in that, go listen to Matt's podcast on the biological age test. It's the OptiSpan.
That's
podcast,
right. Thank you. Yes. And I think that's a good example. You know, there are a lot of diagnostics we can run. What helps and what doesn't help, and in which people do these things help. That's kind of what we're trying to figure out, and I think we've made some progress there.
Great.
As we gather more data, we also anticipate some R&D. Hopefully, we'll identify new ways to probe health and maybe new biomarker signatures. So that's what we're doing at OptiSpan, and our goal really, is to figure out how do we scale this to as many people as we can. And so that's where I think the corporate program comes in, where, at a lower price point, can we offer high-end concierge medical care to employees? And, you maybe won't get everything you can get with the top tier program, but can you get the 80-20 where you can get 80% of the benefit, 20% of the cost, where employers might pay for it, where insurers will actually see value? That time is going to come. I think we're at this really exciting inflection point in the field. I think everybody sees that's going to happen at some point. And this is kind of where I say, our current healthcare system is unsustainable.
Totally.
I think we would agree with that. And I see two paths, right? People like us can actually figure out, how do we get to the next stage? Maybe we'll use Peter's words, medicine 3.0. How do we get there in a way where most people will benefit? Because the alternative is collapse, and that's going to suck. So that's part of what we're trying to figure out and help enable.
I love that you guys are doing that. I was actually unaware. I knew you did the concierge medicine, which is very similar to what I do in LA. But if I can ever be of help too, I feel like collaboration is one of the things that we need to do more of in this industry, where it's like we shouldn't be silos, because we're all gathering all this information and to share it, so we don't have to, like, for instance, I'm not going to do what you did with the biological age test kits because you just did it. And I know it's not like a huge study kind of thing, but it's like, why? Yeah.
But I mean, I think you, and also sharing experiences, right? Like I suspect, I don't want to put words in your mouth, but I suspect you have kind of come to the same conclusion on these biological age tests, right?
100%. Yeah.
So I think when multiple people have, through different paths, gotten to the same place, it's probably the right answer.
Yeah.
Right. And so I agree completely. And Kevin White, who you know as well, was recently on our podcast, and we talked exactly about this need for gathering like-minded people in the space who really want to help kind of with this shift in healthcare, to come together and align on at least a core set of values and principles. And I think that's exactly what we need to do.
Yeah. Well, because I feel like there's this need where, you have your primary care doctor, you go there through insurance, you get the standard test. They don't talk to you much about exercise lifestyle, right?
Right.
And then you have the functional medicine community, which I've used that term in the past to describe myself. And we'll talk about this when I'm on your podcast, but there's a lot of shit that I don't agree with that's happening in that community.
Yeah.
But there's no kind of niche to even describe what this is, besides like some people are saying medicine 3.0, concierge medicine, integrative medicine. Yeah. But it doesn't weed out who is really trying to stay evidence-based and just at the front of research versus who is slinging supplements, selling these eclectic lab tests to make a profit. And we need some sort of filter to be like, okay, if you're looking for this kind of thing, these are the people that are doing that to the best of our ability. And we're still learning, but we're in this camp.
I'm right there with you. And I think this is one of the, we're at a very challenging time in the space. So it's a time of great opportunity, excitement, and real challenges for exactly this reason that, I think most of the providers in this space have good intentions. There are some who don't. There are some who are out to make a buck, but most of them have good intentions. But a lot of them just don't know what's real and what's not, and never develop critical thinking skills. At least that's how it seems to me, and kind of doing all sorts of wacky stuff. And so how do we help people understand what's real, and then hopefully help other providers navigate that? Because again, I think the people who have good intentions
I agree.
will want to have that information,
Yeah.
but it's just really hard. And I mean, maybe that's what I can bring, because I'm not an MD. I don't practice medicine, but I think I have a pretty good handle on what's solid science, what's kind of in that gray area, and then what's just snake oil,
Trash.
right? Yeah. Or at least bad science.
Yeah.
And so I'm hopeful that, we can help add to the conversation, bring a voice of sanity when necessary, and have a big impact.
Great. I'd love to be a part of that if I can help. Okay, rapid fire round. So we're going to go through, I'm going to just say something and you're going to either label it as BS or just total BS, or might be worth it. And so it doesn't mean that it's 100% worth it for everybody, but something that you're not throwing in the trash. There's no nuance here. So you don't get to speak in the middle. We're just putting it in categories. If you want to talk at the end, or if you even want to say, keep it, but nuanced. That's as many words as you can say.
So it's funny because I tried to do this with Peter when I interviewed him recently, and he was really tough. He always wanted to interject. He's
I get it.
So I'm probably going to be the same way, but I want to make sure I understand this. So it has to be complete BS. Because
we're already getting into nuance.
Does the 5% count? It's all about probabilities. You know this, right?
Okay.
So I get it. I'll play along.
Play along.
But recognize that there's very little that is complete BS, and there's very little that is rock solid. So this is kind of like if it's above or below 50%.
Sure.
Okay.
Sure.
All
Okay.
right.
Ready? NADIVs for longevity.
Not much evidence.
Hyperbaric oxygen therapy for longevity.
No evidence for longevity.
Metformin in healthy, normal body weight people for longevity.
Interesting, but not something I do or recommend.
Stem cell therapy for longevity.
Need better data, but really intriguing.
Mm-hmm. Estrogen, progesterone therapy for women.
Absolutely.
Yeah, okay. GLP.
You want to disagree with me?
No. No, I agree.
Okay.
I agree. I was going to say that's for perimenopausal, menopausal women.
Yeah, of course. Sorry. Yeah. I knew where you were going.
GLP-1 agonists for anti-aging longevity.
Very interesting, but no data yet.
Okay. Sauna.
Interesting,
longevity.
but I'm not convinced yet.
Okay.
But interesting.
Interesting. Fasting for longevity.
Good caloric restriction method for some people. Fasting itself in
normal body weight people.
Fasting, let me say this right. Isocaloric fasting, no evidence for longevity. In other words, if you eat more to make up for when you fasted, no evidence.
Caloric restriction for longevity
in laboratory animals. Oh, in humans? I think it probably slows the biology of aging, but the risks probably offset the benefits.
Cold plunging for longevity.
I mean, it's kind of like sauna. Interesting. I think it helps some people, but longevity, no evidence.
Young plasma infusions, parabiosis for longevity.
Works in laboratory animals, very interesting in people.
Interesting.
The problem is there's no evidence for longevity in people outside of diet, exercise, sleep, and relationships, right?
But you're interested in it.
Yeah, I think it's interesting.
Great.
The science is super cool.
Exercise for longevity.
Of course.
Resveratrol.
None. BS. All BS for longevity. All BS. I can't say that any more clearly.
Cool. Red light therapy for longevity.
I'm interested. I don't know enough about it yet. Again, I don't know of any data for longevity, but I'm interested there. Yeah.
I'm going to say this with a straight face. Semen retention for longevity.
I don't want to even, I don't know of any evidence for longevity, and I don't know why you would go there, but hey, each their own.
These are from social media influencers. This is not my collection of things, but yeah, restricting sex, semen retention has been talked about.
So our we didn't talk about this. At OptiSpan, our 4 pillars are eat, move, sleep, connect. I would say with someone you love, sex is an important part of connect. I would not restrict that.
Agreed. Okay. Awesome. Thank you so much. This is awesome.
Of course. Yeah, it was fun.
Really appreciate you coming. And please check out Matt's podcast, OptiSpan. I will hopefully be on one of them because we're going to record that right
Unless
after.
it goes way off the rails.
Unless something happens. But thank you again. Really appreciate it.
Thank you.